Good evening, everybody. Thank you for taking the time to listen to this talk. I'm Dr. Susanna Park from San Diego Fertility Center. And my hope and my goal is that by the end of this talk, that you'll have a bit of a better understanding of what infertility tests are about and what the treatment options are about. So there is a little box for questions. Please feel free to type your questions in. If at any point you don't hear me talking all of a sudden, or I'm talking too low, I have my little question box open. Just shoot me a quick text and let me know, hey, I can't hear you. Okay? All right, so let us start. So San Diego Fertility Center has 3 offices, but the main office is in Del Mar. We also have an office in Mission Valley, which I run, and there's an office in Temecula Valley. So I see patients both in Del Mar as well as in Mission Valley. In order to understand fertility treatment, one must first understand, well, how does pregnancy happen? So let's start with just the basics. So basic anatomy first. This is the uterus. This is the right fallopian tube. There's also a left fallopian tube. This is the right ovary, and there's also a left ovary. When you ovulate, an egg leaves the ovary and goes into the fallopian tube. When you have intercourse and sperm is deposited in the vagina is down here. Sperm is put into the vagina. It then has to swim up the uterus. It goes out both fallopian tubes, right and left, in search of the egg. The sperm travels all the way to the end of the tube to meet the egg at the end of the fallopian tube. So many people think an egg travels into the uterus. It does not. An egg stays at the end of the tube, and sperm travels to the egg. Sperm and the egg combine at the end of the tube, and a fertilized egg we call embryo. The embryo then reverses direction through the tube. And notice here that there are days written because the journey of the embryo through the tube to the uterus takes about 5 to 6 days. And I want you to keep that in mind because this will come up later when we talk about IVF treatment. So after the 5 to 6 days, the embryo will then implant, and only then will you have a positive pregnancy test. Okay. Let's talk a little bit about what happens in the ovary. So unlike men who make new sperm all the time, we women are born with a finite number of eggs. The problem is you cannot see it. Those eggs are embedded in your ovaries. And the only way to know is by taking out a microscope. But that would mean removing your ovaries, and that's not great. So we have to do some indirect tests to get an idea of, gosh, how many eggs do you have left? So one egg test is a hormone called anti-Mullerian hormone, AMH. This is a hormone secreted by the eggs in the supply that we cannot see. But we know that if your AMH level is a good value, then we know, okay, you must have eggs in your supply. Conversely, if your AMH level is a low value, then we know, okay, there must not be that many eggs left in the supply. Another egg test is a hormone called follicle stimulating hormone, FSH. This hormone is very specific to your menstrual cycle, and it should be done somewhere around cycle day 2, 3, or 4 of your menstrual cycle. Cycle day 1 is the first day not of spotting, but full flow. So FSH should be measured around cycle day 2, 3, or 4 of your cycle, because at that time, FSH levels should be low. In the middle of the cycle, it's supposed to rise. So if you measure your FSH level mid-cycle, of course it's going to be high. So we want to make sure it gets measured in the beginning of the cycle when the FSH levels are low. The third egg test is an ultrasound for something called antral follicles. And the name of this test is antral follicle count, AFC. Well, what is an AFC? Well, I just finished saying that you have an egg supply that nobody could see. But every month a group activates. And you see these little black circles on the ultrasound machine. Those black circles are your antral follicles. And we know the more black circles we see, then we know, okay, you must have a lot of eggs in your reserve. And the less black circles we see, then we know, uh-oh, we don't have that many eggs left in the reserve. So 3 different egg tests, AMH, FSH, which is done hand in hand with an estradiol level, and an ultrasound for antral follicle count. So blood work, and an ultrasound. Okay, but what is the significance of an antral follicle? So in this picture, I drew 10 antral follicles. When you don't take fertility drugs in a natural cycle, of these antral follicles, your body will pick one to grow super big to ovulate. That is the egg you ovulate. What happens with the other antral follicles? Do they go back in the supply so maybe you could use it next time? They do not. Any antral follicles that don't get chosen to grow big and ovulate disintegrate. So women many times think, oh, I just lose 1 egg a month. No, you ovulate 1 egg a month naturally, and all the other follicles just die off. And this means we lose multiple eggs every month. And this is why we run out of eggs by the time we're 50. However, if you take fertility drugs, okay, that changes. So if you take fertility drugs, you can prevent those antral follicles from dying. So in this example, I drew these circles to represent that you took fertility drugs and we saved a few of these antral follicles from dying such that you can ovulate multiple eggs. And in this example, I drew 3. Okay. So now that we understand how basic reproduction works and how things work in the ovary, let's now go over your fertility options. So I like to break them down into 3 categories. The first category is timed sex with fertility drugs. The second category is intrauterine insemination. And the third category is in vitro fertilization. So let's talk about each of these. Okay, so let's start with timed sex with fertility drugs. So again, the purpose of fertility drugs is to make multiple eggs grow. But what are these fertility drugs? So they're either Clomid or letrozole. Letrozole is also known as Femara. And these are tablets you take by mouth, and generally you take them for about 5 days. Once you take them, we do an ultrasound so we can visualize, well, gosh, how many eggs are you making? How big are the eggs? And what does the lining of the uterus look like? Is it nice and fluffy, ready to receive an embryo? Once all those parameters look great, then we instruct you to take an ovulation drug. And the drug is called Ovidrel. Now, Ovidrel is not a pill. It is an injection. The needle is about 1 centimeter short, and you inject in the fat layer under your skin. It's called subcutaneous. This Ovidrel causes ovulation to happen about 36 to 40 hours later. So for example, today is Wednesday. If you take an Ovidrel Wednesday evening, you're going to ovulate approximately Friday morning. So once you take the Ovidrel, in this example, you would then have sex to time it. So in this case, it would be Friday morning. So obviously, if you say, oh my gosh, Friday mornings, it's so busy, we have to get to work, then maybe you take the Ovidrel Wednesday morning so that you ovulate Thursday evening. So time sex with fertility drugs is a great starting place. Okay, what are the advantages of it? Well, one, there aren't that many visits, maybe 1 or 2 visits. There's absolutely no surgical procedure, and it's affordable. And I know many people have questions about cost. At the end, I will show you an email, and you are welcome to email them and just get cost of the treatments. Okay, what are the disadvantages of time sex with fertility drugs? Well, the fertility drugs are making you ovulate more than 1 egg. So you must be prepared for the possibility of more than 1 child. 2, with sex, a lot of that sperm just falls out of the vagina. And I know a lot of people will lay their legs up, pelvic rest, all of that, but none of it makes a difference. Okay, but it is a waste of sperm. And the other thing is, if you come back with a negative test and you say, well, what happened? My answer is going to be, I'm not sure, because I can't see your body, right? I don't know how much sperm entered your body. I don't know if the sperm ever found the egg. I don't know if they even fertilized and an embryo was made, or maybe the embryo was made and it just didn't stick. It's really hard to tell what happened because everything is happening in your body. So then we go on to option 2. Intrauterine insemination, which we call IUI. So in IUI, you have the choice of no fertility drugs or fertility drugs. So if you do no fertility drugs, that means you're ovulating you 1 egg. And we are going to work with the rhythm of your body and find the prime time to do the IUI. So that's 1 egg. If you take fertility drugs, for IUI, you have some options. You can do the pills, the same pills we talked about on the prior slide, Clomid or letrozole, also known as Femara. Or you can take even stronger fertility drugs in the form of injections. They're called gonadotropins, and they get you to make maybe 4, 5, or 6 eggs. But be careful, right? If you're ovulating 4, 5, or 6 eggs, then the possibility of twins goes up, but more than twins, right? Triplets, quadruplets, etc. So you take these medications, we monitor you with ultrasound. And then again, when you have good follicle size, good follicle number, and the lining of the uterus looks great, then we instruct you to take the Ovidril, which causes ovulation. But in this case, rather than sex, about 36 hours later, you will bring us the sperm. We will process it, put in a small catheter, and put the sperm into the uterus. Now, if you're using donor sperm, we already will have the sperm because it's frozen. So we just defrost it the day of your IUI. So here's a picture of what IUI looks like. Again, just to go over anatomy, uterus, right fallopian tube, left fallopian tube, right ovary, left ovary. Here's the vagina. Okay, so a speculum is put into the vagina, and then a catheter is placed into the uterus, and the sperm is released in the uterus, versus sex, where the sperm is released in the vagina. So what are the advantages of IUI? Well, there's no surgical procedure. The IUI is not considered surgery, and it takes like 5 minutes. It increases the number of sperm that enters the uterus, and it's very affordable. Well, what are the disadvantages of IUI? Well, fertility drugs have the risk of multiples, right? So if you're ovulating 4, 5, 6 eggs, or even 2 eggs, there's a possibility of more than 1 child. Now, if you opt for no drug IUI, then there is no increased possibility of multiples other than what naturally would occur because you're ovulating only 1 egg. But if you have a negative pregnancy test for the IUI, again, it's hard to figure out where things went wrong because I can't see inside your body. So that's where in vitro fertilization, IVF, comes in. Now in IVF, we usually use hormone injections, the fertility drugs that are injections. Sometimes I will use the Clomid or the letrozole in conjunction with the injections, but we don't do IVF solely with Clomid or letrozole. okay? So use the injections every day for about 9 to 12 days, so about a week and a half. And the goal is to make multiple eggs grow. Now, unlike the other treatments, with IVF, you are seen about 4 times in that 9 to 12 days. Why? Because these drugs are powerful and we need to make sure we don't over-medicate you, or perhaps we under-medicated you. So when you come in for the ultrasounds, this is what we want to see. So this is regular ovary without any fertility drugs. These black circles are the antral follicles. And in a cycle without fertility drugs, naturally you would pick only one antral follicle to grow big and ovulate, and that's this one. And notice how small these are, and these would disintegrate. But if you're doing IVF, this is what I want to see. I want to see many black circles growing big. That's how I know your antral follicles are responding to the IVF drugs and growing. After about 9 to 12 days, you should be ready for your ovulation medication. Now, for IVF, there are different types of trigger shots to make you ovulate. There is the traditional one. And then for people who have quite a robust response to the IVF drugs, we don't want to put you into ovarian hyperstimulation syndrome. So we have other types of trigger shots that are milder and that will minimize your risk for ovarian hyperstimulation syndrome. Once you take these medications, the eggs should be ready for retrieval somewhere between 34 to 36 hours. The retrieval is done in our office. We have a full operating room. And right before your body is about to naturally release the eggs, we take them out. So we put you to sleep with anesthesia by an anesthesiologist. The eggs are removed through the vagina. There is no cut on the abdomen. And it takes 15 to 30 minutes. It's pretty fast. So here is a diagram, again, of what it would look like. Again, just basic anatomy. Here's the uterus. Here's the right fallopian tube, left fallopian tube, right ovary, left ovary, vagina. Okay, so the ultrasound is put into the vagina. Now, normally there is no needle on this, but only for the retrieval do we put a needle here. The ultrasound stays in the vagina, but the needle only passes from the vagina into the follicle. Now, these follicles are full of liquid, and there hopefully is a microscopic egg in each follicle. So one microscopic egg in each follicle. So this needle goes into the follicle and it sucks out the liquid, and hopefully that microscopic egg is in the liquid. There's a test tube at the end of this and it will collect the liquid. And then there's an embryologist sitting there who will put the liquid under the microscope into a petri dish and will tell us if there is or is not an egg in that follicle. So here's a video of me performing egg retrieval. Okay, so this is the ovary, and you could see all these black circles, which are all follicles. This bright white thing is my needle. So here I am, I went into a follicle. Notice how it's collapsing because my foot is on the suction machine, sucking out the liquid. Okay, and I'm scraping the follicle just to make sure that egg came off. Then I go into the next follicle. Again, sucking out the liquid, hoping that there is an egg in there. So each black circle will get deflated. And you could see how easily this is. You just go from one follicle to another, which is why these egg retrievals happen pretty quickly. You're not asleep for hours. This is max 30 minutes that you are asleep. Now, as you can see, there are a lot of black circles here. So this was actually an egg donor, and that's why she has so many follicles. Now, if you're doing IVF for purposes of egg freezing, at this point is where you would stop. Okay, so the same day we take your eggs out, we then look at your eggs and we will freeze the appropriate eggs. So there are 3 types of eggs. Number 1, completely immature, which we don't freeze. 2, almost mature, absolutely we'll freeze those. And 3, fully mature, absolutely we freeze those. So for an egg freeze cycle, you started your shot, you injected for 9 to 12 days, and then we take your eggs out. So it's 2 weeks and you're done. Now, if we're making embryos, then the day that we take your eggs out is when we need that sperm. So if it's fresh sperm, we get the fresh ejaculate. If it's frozen sperm or donor sperm, we defrost it that same day. And the way we fertilize is called ICSI, ICSI, where you take one sperm and you inject it into the cytoplasm of the egg, intracytoplasmic sperm injection. Okay. Now, what if you have two sperm sources, right? Two males trying to have a family. You can take the eggs from the egg donor, divide them in half, and each of you has your own cohort of eggs, and then they get grown separately. And then we'll do ICSI with this sperm source and this cohort of eggs, and then ICSI with this sperm source and this cohort of eggs. Now, a little bit about ICSI. This is the way natural fertilization happens. You have one egg and millions of sperm racing to the egg trying to fertilize. But of the millions of sperm, usually only one egg will fertilize, and then the egg will shut itself off to any other sperm. But in ICSI, we manually put a sperm into the egg. So here's a video of ICSI. So here is sperm. Notice they're moving. So we grab a sperm and we cut the tail so it stops moving. We have the sperm in our pipette. Then we go to the next dish, which has the eggs. Notice the difference in size, right? Eggs are so much bigger than sperm. And this is all still microscopic. Now, one of the beauties of ICSI is because we handle sperm one by one, if you have a semen analysis and the motility is not great or the morphology, the shape isn't great, we will find that sperm that's moving and normally shaped. And that's the sperm we will use to do the ICSI. Okay, now here is the pipette with the sperm piercing the cytoplasm of the egg. Okay, we withdraw fluid from the cytoplasm of the egg. And then inject the sperm in. Right there. Okay, and that is ICSI. So this type of procedure requires a lot of experience and expertise, and only our senior embryologists perform the ICSI. But you can imagine that is one egg, right? So if somebody has 14 eggs and the next retrieval has 16 eggs and the next one has 3 and the next one has 24. So you can imagine the amount of labor and skill set and time and concentration that is required to do ICSI. And so many times people say, my gosh, IVF is expensive, and it really is expensive. But when you think about the time, the equipment, the skill set that you need to do a really good job in the laboratory, that accounts for a lot of why IVF is quite expensive. So once you do ICSI, you then have an embryo. Okay, now just because you put a sperm in the egg doesn't mean it necessarily becomes an embryo. So the fertilization rate through ICSI is generally about 60 to 80%. Okay, embryos are then grown in the lab for 5 to 6 days, right? Why? So remember earlier I talked about how the embryo was formed at the very end of the tube, and it takes 5 to 6 days to travel through the tube to be the right stage of development to stick in the uterus. So we just copy nature. And during this 5 to 6 days, this embryo will cleave, okay, to become what's called a blastocyst. So here is an egg that's been fertilized, and the way we know that, it has 2 sets of chromosomes, 1, 2, so 1 from the egg, 1 from the sperm source. It then divides to become 2 cells, 4 cells, 6 to 8 cells, and by this time it's 3 days old. Then there's this burst of replication of cells such that by here, day 4, it's this big clump of cells that compacts, and then by day 5, day 6, it expands. And there's a fluid cavity in here called the blastocele. Hence, this is called a blastocyst. Okay, and this is around day 5 to day 6. And by this time, it has over 100 to 200 cells. So a big explosion of cell replication. Now, when it reaches the day 5, day 6, you have a few options. One is you say, fantastic, let us freeze. Okay, so why would we freeze? Why don't we do fresh transfers? We can. So I've been doing this now 20 years. And in the very beginning, we always did fresh transfers because at that time, we did not know how to safely freeze embryos so that they would survive. Many times when we froze embryos, they did not survive the thaw. So back then, we put in 3, 5 embryos at one time. But things have changed a lot now. Our freezing technique is so good that it's just as good. The success rates are just as good as that of fresh embryo transfers. Okay. But one of the problems with fresh embryo transfers way back when was we would counsel every patient, you are at 2 times increased risk for preterm delivery. But why would that be? Because when I took all those eggs out from the follicles, those remaining follicles make a hormone called relaxin. But she doesn't have just one follicle that I took eggs from, she has many. So she has many follicles secreting relaxin. So her relaxin level is much higher than a woman who just had 1 egg ovulate and has only 1 follicle making relaxin. Well, relaxin does just that. It relaxes your pelvis. And because your relaxin levels are higher, fresh embryo transfers are 2-fold increased risk of preterm delivery. The other thing we noticed was that when women had a very robust response to IVF drugs, we noticed that their implantation rates were actually lower, which was odd, right? So what we discovered was that when women have these very high estrogen levels, the uterine lining development starts to develop faster. And all of a sudden, the embryo development doesn't sync with the uterus development. So for that reason, and because success rates are the same between fresh and frozen, we really encourage people to do a frozen embryo transfer. Now, in addition, depending how many eggs we get from you, after the retrieval, you have cramping and bloating, right, and sharp stabbing pain. And so 5 days later, you're really not in the best condition to get a fresh embryo. Okay, but I will do a fresh embryo transfers, especially in people who really don't have that many embryos and they've done IVF before and their embryos just will not survive to the blastocyst stage. Sure, I'll do a fresh embryo transfer day 3 or day 5. But in general, we grow to day 5 and we freeze. Now, when we freeze, you have the choice of just freezing, or you could do something called PGT, pre-implantation genetic testing. What is that? Well, PGT checks for number of chromosomes. So a normal embryo should have 46 chromosomes, 23 from the egg source, 23 from the sperm source, for a combination of 46. So PGT will count for every embryo the number of chromosomes. So if you look over here, you will see embryo number 1, 2, 3, 4, 5, all the way to 23. And you notice there are only 2 copies of every embryo. Well, look over here. Notice here, you have 2 copies chromosome 1, 2 copies of 2, 2 copies of 3. But if you go all the way to 21, do you notice that there are 3 copies of 21? That is Down syndrome. Okay, so PGT checks for every chromosome number how many copies there are. Secondarily, chromosome number 23 happens to be your sex chromosome. So by knowing if you have an XY or XX, you also happen to know for every embryo boy, girl. Now that may or may not be important to you, but we have a lot of patients that come to us for what's called family balancing. Meaning, let's say they have 3 boys at home and they just want a girl. So they would come to do IVF so we can help them identify which embryos are the girls. Okay. Once we have the PGT results, then we can get ready for the embryo transfer. So for the embryo transfer, you are wide awake. Again, uterus, right fallopian tube, left fallopian tube, right ovary, left ovary. And it's very much like an IUI, except that I'm not putting sperm inside, I'm putting an embryo inside. So you put a speculum in the vagina, a catheter goes in, and an embryo is put into the uterus. So here's a video of an actual embryo transfer. This is the uterus. And this white line is my catheter. So I'm actually talking to the person, right? So embryo transfers that take like 10 minutes. Okay, here's the inside of the uterus, beautiful endometrium. Now here's the catheter. Keep your eye on the tip of the catheter. You're going to see a flash right there. That's it. That's the embryo transfer. Okay, now you're not actually looking at the embryo because you need a microscope, but embryos are housed by these air bubbles, and the air bubbles shine bright white. So what you're looking at are the air bubbles holding the embryo. Now the catheter does get checked to make sure that it's devoid of the embryo, because sometimes embryos actually are still clinging onto the catheter. And another question I get asked often is, well, can you put 2 in? And it really depends on your age, your embryo condition, and your physician. I do feel comfortable putting 2 in as long as you two have been informed, okay, of the risks of multiples. Now, depending on the medical condition, I may say it's not medically in your favor to put 2 in. But if you're medically healthy and you've been informed of the risks of multiples and you still want to put 2 in, I will put 2 in at the same time. There's no guarantee of twins, okay? So what are the advantages of IVF? Well, IVF has the highest success rates compared to time sex with drugs or IUI. It's also the shortest time to becoming pregnant. Okay, well, what does that mean? So let's say you come and you have these egg tests done and they're okay. They're not amazing, but they're not terrible. They're okay. And now you start to worry, oh gosh, I imagined I would have 2 kids, but oh, I want to have 1, but by the time I have 2, I'll be that much older. You may want to consider IVF because it's your fastest way of becoming pregnant. IVF bypasses blocked tubes. So let's say you do the tube test called a hysterosalpingogram and you realize, oh no, my tubes are blocked. Maybe both are blocked. If both are blocked, options 1 and 2, fertility drugs with sex and IUI, are not feasible options because those both rely on fallopian tubes. You have to do IVF. If one is blocked and one is open, you don't have to do IVF. You could try the more conservative options and then consider IVF. The conservative options are not working. IVF overcomes abnormal sperm. So when we do the ICSI, we manually choose sperm that's moving and normally shaped. Now, let's say you had a vasectomy, right? Let's say you have 2 kids with a prior partner and you decided, I don't want any more children. And then you meet somebody else and you decide, okay, I do want more children, but now my vas deferens has been obstructed. You can still have children. You can either try to reverse your vasectomy, which doesn't always go so well, or you can pull the sperm directly out of the testicle and then use that sperm to do ICSI for the IVF. IVF also assesses chromosome issues. So let's say you have a history of recurrent miscarriages and you've tested the miscarriages and you know that you have chromosomal issues. You've proven it. The tissue came back saying 3 copies of 15. Or let's say you're older and you just seem to have miscarriages. You can't prove it's from chromosomal problems, but most miscarriages are from incorrect number of chromosomes. Then in those scenarios, you do need pre-implantation genetic testing, PGT. So you would have to do IVF in order to do the PGT testing of the embryos. IVF also allows for sex selection, which we talked about. IVF minimizes your risk of multiples. And for most people, they're like, no, wait a minute. I heard IVF causes all these twins, etc. It's true. If we put in 2 embryos, it's true, there's the possibility of twins. But I mean, back in the day, I did put in 3, 4, 5 embryos, but we don't do that now because our technology is so much better than 20 years ago. So many people who say, I don't want 2, I just want 1 child. Your options are either IUI without fertility drugs, so you ovulate 1 egg, or IVF create these embryos and we put 1 embryo in at a time. IVF also allows for various egg, sperm, and uterus combinations, right? It's the beauty of IVF. Okay, so let's say you are a male-male couple, right? 2 sperm sources. We find you an egg donor, we find your surrogate. The egg donor provides her eggs. We divide it between both of you, usually 50-50. You have your respective embryos, and then we transfer the embryo into the surrogate. Okay, that's the same if you're a single male, right? You need an egg donor and you need a surrogate. All her eggs will be fertilized by your sperm. We make embryos, and then the embryo gets transferred into the surrogate. What if you're a female-female couple? You can do what's called reciprocal IVF. In reciprocal IVF, one female is the egg source, and the other female is the uterus source. So this female undergoes IVF. We take the eggs out from her. You tell me who the sperm source is. It could be a friend. It could be donor sperm from a sperm bank. We make the embryos, and then the embryo goes into the other female. Let's say you're a single female. I would encourage you to do IUI using donor sperm. But let's say you do that and it doesn't work. Then IVF is a great option. We also have women, single or with partners, who decide, you know, maybe because I'm older, maybe because of medical conditions, who decide that they will do an egg donor and maybe partner sperm, or female partner eggs with a sperm donor. And these combinations can then be put into a surrogate. So IVF really allows for a lot of combinations to make a family possible for all types of people. But IVF does have its disadvantages. Anesthesia. So the person undergoing the egg retrieval must be put to sleep with anesthesia. And then surgery, right? It's not a big surgery, it's a minor surgery, but it's still a surgery. And the risk of complications is so small, it's like 1%, but I don't want to lie and say it's 0%. It's pretty rare, but it's still a surgery. And then of course the cost, right? The cost of IVF can be expensive. And again, I encourage you to email our office for cost questions. So that is my last slide. And this is the email, newpatient@scfertility.com. If you had any questions about cost, or if you wanted to schedule a follow-up to just get more questions answered. So I'm going to open up my question window now so I can answer the questions. Okay. For egg freezing, is there more of a risk of eggs not surviving during the freezing process or thawing process, or is there an equal chance of damage or loss during both processes? That's a great question. So when you freeze an egg and then you defrost it, in general, 70 to 80% of those eggs will survive the thaw. So for example, let's say I froze 10 eggs, then I'm expecting 1, maybe 2 to not survive the thaw. In contrast, when you freeze embryos, frozen eggs, over 95% survive the thaw. So it's not that common. We have an embryo that does not survive the thaw. So what that means is when you have eggs frozen and then you decide, okay, I'm going to freeze it, and then in the future, I will fertilize it with, let's say, donor sperm, or maybe you find a male partner, just be aware that your number of eggs may be just a little bit less than had you met this person or fertilized out the gate. Okay, did that answer your question, hopefully? And the reason for that is an egg is only 1 cell versus an embryo that's frozen is about 100 to 200 cells. Next question, I'm 33, my husband's 39. We've been having timed intercourse for 6 months. Is it too soon to get tests done, or would you recommend doing some basic tests to see if everything is okay? Which test should we get done first? Okay, so it depends. So technically, you're not infertile. So the definition of infertility depends on the age. So if you're under 35, it's well-timed intercourse for a year, okay, before you go see a fertility doctor. If you're 35 or older, then it's well-timed intercourse for 6 months before you go see a fertility doctor. So if you have insurance coverage and you're trying to use your insurance to get your basic diagnostic tests done, there's a possibility your insurance may say, nope, because you're technically not infertile at the age of 33, you've only been trying for 6 months. If, however, you don't have infertility coverage, meaning you're going to be paying cash anyway, then it doesn't matter, right? Then if I were you, I would say, come to our office, do a consultation. We can give you the list of the tests, right? Because sometimes we have to adjust the test based on your history, etc. And then what you could do is maybe you can take that list, maybe to your primary care doctor or your OB/GYN, maybe they feel comfortable ordering it. If not, then we can tell you where if you pay cash, you can get a good, pay less than if you went to a more expensive lab to get those tests done. And sometimes all you really need is really just peace of mind, okay? Just to figure out, okay, we're good. So then we feel comfortable that we're gonna keep trying on our own. Okay. Next question. What are the risks of PGT? So again, just to make sure we're on the same page, PGT is when you biopsy the embryos that have made it to day 5, day 6. Okay. So the damage rate from PGT is less than 1%. But one of the risks of PGT is, you know, PGT was never intended for young women. It was intended for women in their late 30s, 40s, where the majority of the embryos do not have the right number of chromosomes. But when you apply this test to women who are much younger, let's say somebody who's 30, the test becomes less accurate. And so you just have to be prepared that the PGT results may not turn out the way you have thought they would, right? So maybe you may realize, oh, wow, Dr. Park said that most of my embryos will be normal, but wow, it's like half-half, right? Because you're using the test in the incorrect patient population. So with my patients who are mid to late 30s and 40s, I do encourage them, please do PGT. When people are much younger, I tell them, just so you know, PGT is really not indicated in your age group. So in your age group, I would encourage you, let you know that it's optional. Okay. Next question. Okay. If you typically get your period every 26 days, will you need to prep for egg freezing with birth control pills? And if so, does birth control pill negatively affect follicle or egg number for that cycle? Good question. So there are different ways to prep for an IVF cycle. So you can just get your period and day 2, day 3, baseline, if everything looks normal, boom, start IVF drugs that night. And there's nothing wrong with that, okay? The way we do it here is we like to give you some prep, some pre-IVF hormones the month before you plan to do the IVF. And the reason for that is a couple of reasons. One is, if I can get your follicles to all, what the prep does is it pauses your cycle. If I can get your follicles to all pause at the start line, just for a couple of weeks, then I get you off the pre-IVF cycle and bam, you start the IVF drugs. Your follicles tend to grow in a more synchronized manner, as opposed to having a few follicles big, some small, right? You want them to grow synchronized. So they're all about the same size because the bigger the follicle, the more mature the egg. Now, our pre-IVF hormones they're not foolproof. So sometimes I use it and I'm like, oh man, the follicles aren't growing synchronized, okay? But that's why we try to use the pre-IVF hormones to try our best to increase the odds your follicles will grow in a synchronized manner. Another reason why we use pre-IVF hormones is to help with scheduling and timing. So I batch my cycles, meaning that by me controlling when you stop your pre-IVF hormones, I can control when the IVF cycle happens to make sure that I'm not traveling from work, that I am here. So that also allows you, we can give you a schedule. We can say to you, this is when you're starting your IVF shots. This is the week of your retrieval. So for work purposes, you can also plan accordingly. But sometimes my IVF series dates, the batch dates, don't really work with your schedule. And that's okay. You can do the IVF at a time that's convenient for you. Okay. The only issue is if I'm traveling for work, then one of my colleagues will do your retrieval. Now, for the pre-IVF hormones, there are different types. You mentioned birth control pills, and you're right, that is a common one. Birth control pills are great. They are effective. They are strong in pausing the growth of your follicles. But if you are a woman and your egg count is, when you put somebody like that on birth control pills and then you take it off and bam, you start the IVF drugs, the ovaries sometimes are so suppressed that they are slow to wake up and respond to the IVF drugs. So if I have a patient whose egg test results are so-so or really not great, I will not use birth control pill. I will use other medications like estrogen or testosterone as the pre-IVF cycle drug. My wife has had 3 ectopics with 2 emergency surgeries. Both tubes are removed. Okay. We have done 2 rounds of IVF and miscarried both times, about 10 weeks. So, do you have any experience and do you think we still have a chance? So here are the questions that go in my head. Number 1, how old is your wife, right? So the older, the greater the chance of miscarriages. 2, were these embryos PGT tested, right? Because the first 2 were ectopics, right? So those went in the tubes. You then had surgery, so I assume there are no fallopian tubes. So, right, you did say both tubes are removed. So now you did IVF and yet you still miscarry. So I'm thinking, were these PGT tested? If they were not, then I strongly encourage you to consider another cycle with PGT testing. If they were PGT tested and still miscarrying, then I'm thinking, okay, I'm not so sure it's embryo. It may be something about the uterus or the carrier, meaning her overall medical health. And maybe would you consider having the other one of you carry? Okay. So, so just turned 39. Yeah. Okay. So I would definitely do PGT testing, but if they were PGT tested and she miscarried twice, there's something else going on. And I don't think it's embryo. I think it's uterus or some underlying medical condition. So underlying medical conditions that make people prone to miscarriages, chronic diseases, poorly controlled diabetes, poorly controlled high blood pressure, being overweight, autoimmune conditions. A lot of chronic conditions make you prone to miscarriages or not getting pregnant because your body is trying to work so hard to get these medical conditions under control. So if you can get your chronic conditions optimally controlled, then that gives you a better chance of a live birth. Okay. Okay, next question is, how long does it typically take to prepare for the treatments? It depends. So generally, we have you do a new patient consultation, and at that time, we take your history, etc. And then once we have your history, we can get an idea of what tests you need to do. Obviously, we have our standard tests, but sometimes based on your history, we have to order some extra tests. We then do another appointment to go over the results of that test. And then at that appointment, we then determine what the best treatment is, and then we proceed with that treatment. Now, some people, especially if it's pretty straightforward, you can actually do all the standard tests before the new patient appointment, so that your new patient appointment is a combination of, hey, new patient, let's get to know each other. Oh, and by the way, here are my tests. So what treatment do you think we should do? We call it fast tracking. You can do that as well if you'd like. Some patients, are ready to go, and for other patients, it's just too much, and they need it more separated. So in the separated protocol, you make your appointment, we give you the list of tests, you wait for your period to do your tests, then you schedule another appointment. So that usually will be 2 months later. And then at that appointment, we decide what treatment you need. And if it's options 1 or 2, times sex with drugs or IUI, then next month you could start. If it's IVF, then that next month you do your pre-IVF cycles, okay? Then the month after that, you do the actual IVF treatment, okay? Okay. The next question is, do you have much experience with surrogacy? And the answer is yes. So we service the local population and do a lot of these fertility treatments, but we actually have a big egg donor and surrogacy patient care, and that's because we service all types of people. Okay, so we actually happen to have our own egg donor website, our own egg donors. You don't have to use our egg donors, but it will save you a lot of time and money. And the egg donor website is eggdonors.com. So eggdonors.com. And in a year, we do over 500 egg donor cycles. A lot of these cycles, not all, but a lot of them will then be transferred into surrogates. So we don't have our own surrogates. We do have our own egg donors. We don't have our own surrogates. And the reason for that is just with this volume of surrogates that we do, there's no one entity that has that many surrogates. So we partner with a multitude of really good surrogacy agencies, obviously in California, but scattered throughout the United States. And surrogacy is the most expensive in California for a number of reasons. Number one, California has one of the friendliest surrogacy laws. When that baby is born, your name's automatically go on the birth certificate, okay? And two, the cost of living in California is higher, which is why the surrogates get compensated more. So we can easily refer you to surrogacy agencies both inside and outside of California so that you can make the best decision for yourself. Okay, the next question is, do you typically grow more follicles while on the hormone injections prior to egg retrieval? Or you're pretty much going to be working with the baseline number of follicles you naturally have? Okay, so remember, every month your body activates these antral follicles. That is the eggs that will respond to the IVF drugs. So at the baseline IVF, we will count the number of antral follicles. So if it's 8, then 8 is what you should realistically be expecting. Now it's just a guesstimate, right? Sometimes it's off by a few digits, but if I see 8, I'm not expecting 25 eggs. I'm expecting 8-ish eggs, okay? A common misconception people say is they say, well, these IVF drugs will make me go through menopause earlier. They don't. Remember, those antral follicles for that month, whatever you don't use, you will lose. Okay, these are not your future eggs. Do you recommend doing in vitro genetic carrier screening prior to egg freezing? Would that only be necessary prior to moving forward with IVF? Yeah, I would not recommend it unless you're planning to fertilize. So what is genetic carrier screening? So I had talked about PGT testing, which talks about number of chromosome testing in the embryos. Genetic carrier screening is totally different. Genetic carrier screening screens the egg source and the sperm source for different DNA mutations. We all have DNA mutations, cystic fibrosis and sickle cell, Tay-Sachs. We all carry something. But if you carry one mutation, you're generally okay. But if you and the other person carry the same one mutation, then there's a 25% chance you will both give it to the embryo at the same time, which means 25% chance that your child will actually have this disease. So when you have the intention of becoming pregnant, creating embryos, we don't force, but we do encourage both the egg and the sperm source to do DNA mutation testing. Right now, we have the technology to screen for about 300 to 500 different mutations. But the reason why we don't force people is because there are thousands of mutations and we don't know how to check for all of them, okay? And some people just don't want to know. But if you do want to get tested, please try to do it sooner than later because it takes a whole month to get the results back. If you choose not to get tested, that's fine. You just have to sign a waiver saying, yeah, we're not interested. So what happens if you both are carriers for a disease? Okay, so when we talked about the embryo doing the testing for the PGT, you can actually use that tissue sample and then test those embryos for this mutation. So let's say you were both carriers for cystic fibrosis. We would create a probe matching the mutation sequence of your cystic fibrosis mutation. Then once we have the embryos, we then use this probe and see which embryos it sticks to. And if it sticks to it double, right? That means you have 2 mutations, then those embryos would be discarded. So that, because that embryo would have cystic fibrosis. Okay. The next question is, okay, is it possible to evaluate beforehand to see if a woman is healthy and able to carry to full term? Great question. Kind of, but not really. So before we do a transfer or even just IUI, we do tests of the uterus. Okay, but it's just to look anatomically. But what we don't know is we don't know if at the cell level, if that uterus is truly able to carry a pregnancy to term. We don't know that. Okay. Also, carrying a healthy baby to term relies more than just a functional uterus. It relies on her overall medical condition. And sometimes conditions arise like, oh, I didn't know she had this, right? So you've heard of women who are pregnant, all of a sudden she has a blood clot. Pregnancy is a state of thick blood. And she didn't know she had blood clots before. All of a sudden she's pregnant. It's like, oh my goodness, I didn't know I had this underlying predisposition to thick blood. So sometimes like medical conditions are discovered during pregnancy. So there's really no way to know if a woman can carry a baby to term in a healthy manner until she actually goes through pregnancy. I mean, short of obvious anatomical problems with the uterus. Okay. Okay. Oh, you're welcome. Somebody said thank you for the talk. You're very welcome. Let's see. Okay, so the next question is just for our IVF lab, the years of experience, etc. You're right, but the quality of an IVF center is only as good as its IVF lab. Absolutely. Okay, so we have about 12 embryologists in our IVF lab. We have an in-house IVF lab director. So there are some fertility centers, they all have lab directors, but they're not dedicated to that one clinic. They actually manage different fertility clinics. And it's not good or bad, right? But because we are just such a big center with a big volume, we have a lab director that works solely for us. And we have embryologists that work in shifts because we want to make sure that they're not tired, right? When they're doing your ICSI, we don't want them to be exhausted. We want them to be focused and highly concentrated. So we have a group of embryologists that come in the morning and then they are released. And then we have the afternoon group that comes and works through to the evening. Oh, and then the other thing is, how do we maintain the quality of our lab? So we have over 500 egg donor cycles in a year. So, and I mentioned that because these are young egg donors, right? So we know that their embryos should be good quality. So in many ways, that's our quality control, right? If I have embryos from an egg donor and they're doing beautifully, and I have embryos from a 40-year-old and it's doing so-so, I'm not going to think, what's wrong with my lab, right? I'm going to think, okay, this came from a 40-year-old egg source, and that's probably why the embryos aren't doing so well. But if I have a bunch of egg donor embryos not doing so well, the first thing I think of is what's happening in the lab. Okay. The next question is, the next question is, there are a lot of IVF centers in San Diego. Yep. And how do we know which is the best fit? You know, you don't, right? But I will tell you that there are a lot of centers in San Diego really are good centers. It's not like we're living in the middle of a country where there are so sparse in technology and quality. No, a lot of the centers here really are good with great labs, good embryologists, good doctors. And SCFC is not the center for everybody. It's just not. And I think it's important that patients have a positive experience. And so I encourage you, there's nothing wrong with interviewing different fertility centers, right? Do a consultation here, do a consultation there, and just go with your gut feeling, right? You just sort of know when you talk to somebody that, yeah, this feels right, or you feel like, I felt like I didn't really jive, okay? One of the things about SCFC, which is what we call ourselves, that I do want to mention, and I think it's very important to be transparent about this, is I have patients, and they are totally right in desiring this, is they want to be able to see their physician at every ultrasound. And our model in this practice, and it's just a different model, I'm not saying it's better or worse, it's just different, is we have sonographers, we have people doing the ultrasounds. And then every day from 1:30 to 2:30, we, the physicians, go over all the patients that came through. We look at the ultrasound report, we look at the blood work, and we make our clinical decisions. Now, when I'm actually from New York, and when I was at Columbia University there, we did over 2,000 IVF cycles a year, which is a lot. I mean, here we do about 1,200, which is still a lot. But there, we had 10 physicians, and the physicians did all the ultrasounds, right? So I know what it's like to be scanning patients, seeing your patients. But one of the problems was I wasn't necessarily scanning my own patients. And so sometimes patients would get frustrated saying, well, where's my doctor? I haven't seen my doctor for the past month. I'm like, oh, I know, because it was just my day to do the ultrasounds. So I think that if you're the type of person who really wants to see the same doctor all the time, I think a more boutique, smaller practice just may be more appropriate, because I don't want you to be disappointed by your experience here, okay? But then why do so many patients come here? Because we have the great success rates we have. And even though we've learned that even though you don't see your doctor at every appointment, we are watching what's happening, and I do intervene and I say, whoa, wait a minute, the cycle's not going so well, it's going sideways here. I call you and I say, okay, listen, we've got to talk, the cycle's not going so well. Okay, but I think it's okay to interview different clinics. This is a lot of money you're spending, not to mention the emotional investment and the mental investment. And you deserve to be at a place that you just know you're at the right place. Okay, so the next question is the process of egg freezing a fairly simple process that has been standardized, or do different labs have different methods? So it should be vitrification. Okay, I mean, 80 years ago, we were doing slow freeze, which is a slower freezing. And the problem was it would crystallize the eggs, and then many of them wouldn't survive the thaw. It must be vitrification. But I think here, I think all the clinics vitrify. Even embryos are vitrified. Yep, can I use my HSA or FSA for egg freezing? Yep, so many people, it's like the thing now for young women to egg freeze. And at your age of 30, it's the optimal age to egg freeze. The optimal age to egg freeze is late 20s or early 30s. Now, I have so many women in late 30s, 40s coming to egg freeze. It's not that you can't, absolutely you can, but if you are young and you have the resources, especially the coverage for egg freezing, you ideally want to do it when you're younger, because you'll have better quantity of eggs and better quality of eggs. So yes, you can use your benefits, but also more and more companies are offering egg freezing benefits. So if you have that, I would really encourage you to utilize it. Because I have a patient who had benefits and now her company just took it away. So we're like racing to try to get her egg freeze cycle in before she loses her benefits. Okay. Good question. Do you need to get your IUD removed? The answer is no. You do not need to get an IUD removed for an IVF cycle, be it egg freezing or embryo creation. Now, obviously for embryo creation, before the transfer, you'd have to get it removed, okay? But let's say you were making embryos just for fertility preservation, right? You have a partner, but you guys aren't ready to have kids yet, so you just want to put embryos on ice and you've got benefits. Keep your IUD in, you don't need to remove it. egg freezing, keep your IUD and you don't need to remove it. And I'm assuming your IUD is a Mirena or Kyleena. Yeah, you don't need to remove it, right? Crazy, right? Yeah, no, you keep it in and then the IVF drugs will just take over. Okay, and I think that's it. Well, thank you so much, everybody, for your time, for these great questions. And I really hope you found this session helpful. I know that infertility it's a tough struggle, okay? And some of you aren't infertile, like some of you are just egg freezing. But this whole world of infertility is almost like this nebulous cloud that people find very confusing and overwhelming and scary. And I really hope that by breaking it down, it gives you some clarity. And maybe you'll be less intimidated. And so when your doctor talks to you about all these options, maybe it will make a little bit more sense. Okay. Thank you, everybody, and I hope you have a great night.